Hello, my name is Wai Leung. I'm from the University of Hong Kong. It's my pleasure to present our studies entitled Private Gastroscopy and Mortality in Patients with Gastric Cancers, a matched retrospective cohort studies, which is published in GI Endoscopy. We all know that gastric cancer is the third leading cause of cancer death in the world, and screening gastroscopy is rarely performed in most countries except in a few East Asian countries like Japan and Korea. A majority of the gastroscopy are performed in clinical practice as a diagnostic workup or surveillance for upper GI symptoms. So the ultimate questions of whether routine daily gastroscopy also affect the clinical outcome of gastric cancer patients. So the aim of this study is to determine the all-cause mortality in patients who had gastroscopy performed at different time intervals before the diagnosis of gastric cancers. So this study is based on the Taiwan's National Health Insurance Research Database, or the NHIRD. The NHIRD is a compulsory national health insurance program which covers whole Taiwanese residents. And this is a nationwide matched retrospective cohort studies. We include all patients who were newly diagnosed to have gastric cancers in Taiwan between year 2002 and 2007. We retrieved the number and the date of last gastroscopy performed for any indications in these patients before the diagnosis of gastric cancers. However, we exclude gastroscopy performed within 6 months before the diagnosis of gastric cancer, as these endoscopy may be performed for diagnostic purpose. And all 3 cohorts were followed up from the date of cancer diagnosis to the date of death, or at the end of 2012. The 3 cohorts were classified according to the timing of the most recent endoscopy into between 6 months and 2 years. The second cohort includes patients who had endoscopy performed between 2 and 5 years. The last cohort had no endoscopy performed within recent 5 years. And 3 groups were matched for age, curative surgery for gastric cancers, H. pylori eradication therapy, and a post-metastasis score which was based on gender, comorbid illness, and concurrent medications. The 3 cohorts were matched in a 1:1:4 ratio. And the primary outcome of the studies is the hazard ratio of all-cause mortality, whereas the secondary outcome is the hazard ratio of gastric cancer-specific mortality. This table shows the baseline characteristics of the 3 cohorts after matching. You can see that 3 cohorts were matched in age, gender, and also comorbid illness and concurrent medications used. And this is the result of these studies. On the left-hand side, show the all-cause mortality of the 3 cohorts, as well as the right-hand side, show the gastric cancer specific mortality of the 3 cohorts. You can see that in both figures, the more than 5-year cohort has significantly higher mortality for both all-cause mortality as well as gastric cancer specific mortality when compared to the other 2 cohorts. And the other 2 cohorts have very similar overall mortality. And this table tries to show the multivariable Cox proportional hazard model analysis for all-cause mortality. And you can see that those patients who were in the less than 2 years cohorts and the 2 to 5 years cohorts has significantly reduced hazard ratio of death from gastric cancers. You can see that the hazard ratio was 0.8 for less than 2 year cohorts and 0.83 for the 2 to 5 year cohorts. And also age, curative surgery for gastric cancers, chemotherapy, and some comorbid illness were also associated with all-cause mortalities. And this table tried to look at cancer-specific mortality. Again, you can see that the hazard ratios of the less than 2 year and 2 to 5 year cohorts were significantly lower when compared to more than 5 year cohorts. The hazard ratio was 0.8 and 0.83 respectively. And again, age and also surgery for gastric cancers and chemotherapy of gastric cancer were significantly associated with gastric cancer-specific mortality as well as H. pylori eradication therapy. So, ladies and gentlemen, in conclusion, gastric cancer patients who had gastroscopy performed within 5 years before the diagnosis have significantly lower mortality when compared to those who had not had any endoscopy within 5 years. And our results may support the role of repeat endoscopic examinations or surveillance endoscopy in selected high-risk patients. Thank you for your attention.